My talk was about monogenic diabetes, and it was entitled Back to Bedside, so it was a clinical view about these subjects. And I think that the main message I would like to deliver is that although we know monogenic diabetes for more than 40 years now, and although many studies have shown that the majority of monogenic diabetes can be diagnosed by either classical technique of sequences or with the next generation sequencing techniques that are available for, let's say, 5 years. Despite these facts, it has been shown that 80 to 90% of the patients with monogenic diabetes remain undiagnosed. And this is why, this is because these patients are diagnosed either as having type 1 diabetes or type 2 diabetes. And so the question is, what is the reason, what is the main reason for this situation? And I think that the main reason is that many of the physicians, including diabetologists, are not well aware about the existence of these diabetes subtypes, and that they are not certain about the clinical benefits for the care of the patients that may be driven by these diagnoses. Although there are many studies, and I will not discuss all the data here, there are many studies that show that there are much more important consequences for the patient and for the care of the patients when you diagnose a diabetes subtype than when it's not diagnosed. This is the case for the treatment of the patient, which can be tailored to the diabetes subtype, for the prognosis of the patient, the clinical course, the care of the woman with pregnancy, the risk of diabetes complications, and so on. So there are many benefits to make this diagnosis for the patient. So now our goal is to try to increase the rate of diagnosis of these monogenic diabetes subtypes, first by teaching the existence of these diagnoses to our colleagues, second by better phenotyping the patients with diabetes in order to make differential diagnosis with type 1 or type 2 diabetes, and to improve access to genetic screening for these patients.